Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful.
Hello, everyone, and welcome to another episode of Muted in Medicine podcast. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they're unprepared to face, and spreading more awareness about it. And with this podcast, we're going to discuss some of the most silenced topics in medicine that are often not openly discussed. Today, we're talking about PTSD, post-traumatic stress disorder, a condition that affects an estimated 12 million adults in the U.S. each year. While it's often associated with combat veterans, PTSD impacts people from all walks of life, including healthcare providers, where it's estimated that nearly 1 in 5 may experience symptoms due to workplace trauma, especially in the aftermath of the pandemic. This number was higher in nurses. PTSD can develop after a single traumatic event, like losing a patient unexpectedly, or from cumulative stress over time. It can affect your ability to work, connect with others, or even trust yourself. But what's often left out of the conversation is that PTSD isn't a sign of weakness. It's a natural response to extraordinary stress. Today, we're unpacking what PTSD looks like, how it affects healthcare providers specifically, and why addressing it openly is crucial for healing. Whether you're experiencing PTSD, supporting someone who is, or just curious to learn more, this episode is for you. To discuss this with me today, I have Michelle Schuster. Michelle Schuster is a pediatric hematology oncology nurse with a strong passion for nurse-driven research and supporting and addressing workforce issues. Her specific research interests include PTSD in nurses and enhancing staff support. She's a co-developer of HART, a nurse-led program that provides real-time support to oncology staff. And she's also a co-developer of a Promoting Resiliency series. Michelle has been published in several journals and has presented her work locally and nationally in conferences. She's currently enrolled in a PhD program at UMass, Dartmouth, and is expected to graduate in 2025. Within the last year, Michelle has moved from bedside nursing to a nursing management role where she leads an inpatient peds HEMONC nursing team. And she continues to do her work to foster a positive workplace environment to best support her staff and the patient and families on the unit. Michelle, welcome to the show. We ask everybody this question first on the podcast. What is bringing you joy in medicine today?
Oh, I like that question. I think what is bringing me joy is the fact that nurses and my team and my staff are still able to find moments to laugh, and they're still able to find moments to gather and be together. So whether that's celebrating a birthday, celebrating an anniversary, or somebody just got engaged, I think it's the small moments that we celebrate together that just makes us stronger as a team.
Yeah, despite the hard stuff, right? There's still something to celebrate. Yeah,
absolutely.
I love that. Can you tell us a little bit about your background and what inspired you to focus on your work on PTSD among nurses and healthcare workers, and any personal story or any other story that you'd like to share?
First of all, just thank you so much for allowing me this forum to speak to you and your listeners. I feel like this topic of post-traumatic stress disorder, PTSD, in nurses and in healthcare workers is so important. And often, as you mentioned, it's not talked about. So I really just want to talk a little bit today about my journey. So just a background about me, I grew up in a military family. My dad was in force, so most of my life I call North Texas home. I moved around a little bit, but North Texas is what I consider home. I've been a pediatric hematology oncology nurse for my entire nursing career. So I'm about to hit 10 years next week. So that's
Nice.
been my passion.
Congratulations.
Thank you. And then, as you mentioned, most recently I've transitioned into a nurse manager role. So talking to you today with also the lens of nursing management and leadership is really important, I feel. So how I kind of came into this idea and really became passionate about PTSD in nurses is due to my own workplace experiences and experiences with post-traumatic stress disorder. So it wasn't really until I moved away from my first new graduate nursing job about 2 years after I worked there and I moved to Boston that I really began to process some of the things that I had experienced. And I was working with a therapist, and she was the first one who actually said, Michelle, it really sounds like you actually have post-traumatic stress disorder from that first position. And immediately I was kind of thinking, okay, I'm not in the military myself. I've never been deployed. This isn't a thing, right? And it was through that conversation that my whole lens opened up when she was like, it's a thing, and let's talk about it. And so it just so happened that I had my annual review at my job in Boston that same week once I was talking with my therapist. And I talked to my current manager, who's now my senior director, and I was like, I'm kind of thinking about this idea about nurses and PTSD. And she's like, that's a great idea. Did you know we had an evidence-based practice program? Did you want to join it and look into this more? And I'm still so appreciative to this day of the fact that she didn't say, oh, that's not a thing, or, oh, that sounds silly. But she actually just said, if you're passionate about this, there are opportunities and there are pathways for you to kind of explore this question further. So I was able to complete an evidence-based practice program. And then I went on within my hospital to complete a 2-year nursing science fellowship, which is where some of my publications came from. But I've been really focused in now in my PhD about post-traumatic stress disorder in nurses. And now I'm looking at predictors or factors and how do we kind of acknowledge what's going on in healthcare today and how do we address it? So you kind of ask about my story too. And I like to say that it wasn't just one big event for me that left me with my post-traumatic stress disorder, but instead it was different kind of micro stressors over time. So for example, one situation that stands out to me in particular, I was a new graduate nurse. I was working permanent night shift, and the charge nurse texted me probably when I was like maybe 2 or 3 months off orientation and said, hey, just a heads up. Your assignment today, your patient will likely pass away. So I was like, okay, I've got kind of an awareness of I'm going into my shift knowing this might be my first end of life experience. So, okay, I can do this. So I walked into the room, got my report. And when I started doing my assessment and starting to talk to mom, I realized mom was asking me questions like, why is his oxygen so low? Why is he doing this? Are the doctors concerned? Are we going to add new things? Are we adding new antibiotics, new things? And I was like, okay, I think there's a disconnect here because I know the healthcare team knows that we're very close to end of life and this poor mother is not on that same page. So I left the room, called the night resident, and I said, hey, I really feel like we need to have a bigger conversation right now. And he said, I can't come over right now. And that was kind of the end of that conversation. So I'm left and I'm like, okay, so this patient might die in the next 12 hours. This mom is not ready for this. Am I equipped to handle this? I don't know, but I'm going to have to deal with this. Called my charge nurse and she said she was also newer in the role. So I've never dealt with an end of life experience. Sorry, I can't be helpful to you. So I'm a new nurse, 3 months of experience. I'm handling this situation and I'm feeling alone. I'm feeling scared. And I'm also feeling like I'm doing a disservice to this family. So sitting with moments like that and multiple moments like that over the course of what ended up being about 2 years just left with me with this feeling that I can do better and I have to do it somewhere else to preserve myself and to be able to carry on in a profession that I truly love. Being a hemonc nurse, a pediatric hematology oncology nurse was something that I felt so passionate about. And I knew that if I wanted to try to keep doing it, I had to move away or try something new, try with a different team, a different organization. And that move for me was personally the best thing that I ever did. So it wasn't until I moved to Boston and I got a new therapist and I started working through some of these things that I was able to process some of that trauma that I experienced from my first position. So it was a journey, but my personal experiences are one that has completely altered and shifted my nursing and my professional trajectory.
Yeah, that's rough. I'm sorry that happened to you because it's sort of a moral dilemma as well, right? When you're stuck there and you don't have the resources and support that you ask for and the help that you ask for. And I think about nurses is they're always at the bedside. Like they always have to be there, so they can't really say that I can't come right. Like they're always there, so they always have to answer the questions. So yeah, I bet that was really tough for you. So you've done a lot of research on this too, but how common is PTSD in nurses and other healthcare providers? And if you can talk a little bit about that.
So when considering PTSD in healthcare across the United States, but even comparing it to the general population, nurses and healthcare providers are experiencing PTSD at higher rates than that of the US population. So it's important just to put that into perspective. So within the published literature, again, it's not surveying every nurse or every doctor in every institution. So we only are working with what's available in the literature. But what we've been seeing is publication and awareness of PTSD in our profession has increased since COVID-19. So probably since 2020, 2021, there has been an increase in literature that's available regarding this issue of post-traumatic stress disorder in healthcare workers. But it's also important to note that this was present and this was occurring before 2020, 2019. And a lot of my interest kind of started around that 2018 spot. So even though there has been a spike in literature, this was happening before, and the COVID pandemic really just created an opportunity to shed light on the mental health of our workforce, which is incredibly needed. But it's been spanning since probably the beginning of time. And it's just interesting to be able to say, like, okay, we're spiking now, but there's things before that also impacted nurses. In the literature, when you're looking around, you're going to see a very wide prevalence rate. So I can't sit here and just say exactly this percentage, because it varies. And what I mean by that is some researchers will choose to measure certain PTSD symptomology, so maybe a piece of post-traumatic stress disorder, or just report out on a few symptoms, while other will actually measure full diagnostic criteria. So some are reporting maybe up to 96 have symptomology of PTSD, while others will measure full diagnostic criteria, which is, anywhere between 6 to 9%. So somewhere in there, depending on where you're looking. So there's a lot of different factors. Also added to that, there's a lot of different tools. So there's a lot of different ways to measure the same thing. And within the literature, there was at least 5 different tools that I found that researchers utilized to measure post-traumatic stress disorder. So some of those aligned with different versions of the DSM. So whether it was 4 versus 5, or whether they needed a quicker tool, like a more abbreviated tool. So there's just a lot of variation out there. So we're not able to actually correlate from this point to this point because it's measured a little bit different. But all data points are very valuable. It's just interesting to think about for future research. How are we measuring this, and are we utilizing the most up-to-date DSM-5 criteria going forward?
Yeah. And how would you define PTSD? Like, if you just talk about PTSD in general, how do you define PTSD for listeners who haven't heard about it before?
I know. So I think the quickest way to kind of say it's a mental health disorder. So that's what's going on out there. According to the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, there are 4 different criteria. So it's important to talk about that. So what are these symptom clusters? So these are re-experiencing, avoidance, negative cognition and mood, and the 4th is hyperarousal or reactivity following a stressor. So those are some of those symptom clusters to be aware of. And it might look different in every nurse or every healthcare provider. So it's important to note that you and I, we could be at the bedside together and maybe we're in a code or maybe we're experiencing something. I can walk away and maybe I'm completely fine. And maybe you're walking away with an extremely different experience of how that event happened. So just because a code or something, like we can't just say, well, that in itself is going to cause PTSD. It's very dependent on that individual. So it's subjective depending on where that individual is coming to that experience.
Yeah. And you talked about those factors, but I don't know if somebody is thinking about what can the signs and symptoms they can see themselves or others. Like, can you talk a little bit in layman term, like what would PTSD feel like? Yeah.
Yeah. So when somebody says re-experiencing, okay, great. What does that mean? So maybe you're realizing after my shift, I'm replaying these images. I'm having those conversations of, maybe that end of life situation with the family. I'm having dreams. I'm having, just like I keep living it again and again and again, even though I'm out of that situation. So that's kind of one of those re-experiencing. Avoidance. Maybe I just choose not to care for a patient with that diagnosis anymore. Or maybe I really can't enter room 602 without feeling a certain way because something very traumatic happened there just a few weeks ago. So maybe that avoidance, you don't even recognize it as avoidance, but something else is going on a little bit deeper inside you. And negative cognitions and moods. So whether that's, am I feeling maybe more depressed or withdrawn? Am I not enjoying the things that I used to? Is something just different about myself in general? And then hyperarousal. So that can be, maybe let's think about, okay, you got an admission or something happened unexpected. There's a bump in the road a little bit that you weren't expecting. And your hyperarousal, your kind of alarm bells are going off and you don't really know why. So maybe the situation in itself doesn't cause for it, but you're on high alert or your stressors, your cortisol, everything is rushing and you're on top of things and you're like, oh, why am I up here when the situation doesn't require me to be up there? So your body is sensing something inside because of what's happened or because maybe your brain is making those connections when it's not a danger situation. We don't need that fight or flight. We don't need to be activated in that way. And yet we're activated. So that's one of those things.
Yeah, that makes sense. And PTSD can, you think, develop over time? So it can be some sort of cumulative trauma, or it can be one particular event that kind of ignites it to you? Yeah.
Absolutely. And that was what's really interesting too, looking at the literature and showing that there are, of course, those very traumatic situations that happen. It was like one thing that you can kind of put your finger on, like, this is sticking with me. But other things are more subtle. And some researchers have actually said that the accumulation of those develop into PTSD symptoms over time. So thinking about my experience of feeling alone, feeling unsupported, feeling like I am scared when I'm walking into work, those little things are what kind of can accumulate for people over time and actually can cause PTSD symptomology.
So you would say like the lack of support that you kind of felt over time kind of went into it, culminate. Well, just why do you think nurses are more experiencing it more or more prone to it? Is it because of the nature of their work, or what do you think?
So from what I'm seeing in the literature is also kind of in my own personal experiences too, but just thinking about the nature of your shift. So for nurses, those direct care, depending on what setting you're working, you're at that bedside for 8 hours, for 12 hours. You are with that family or those patients nonstop. You are always in there, coming in and coming out, and you are the closest to the families. And maybe with other professions such as, providers or advanced practice providers, you're very much in it at the bedside too, but you're also a layer removed. So it's kind of a little bit different. So I think the opportunity for exposure increases when you're in those rooms all the time or when you're kind of constantly at that bedside. So I think it occurs with frequency.
Yeah, just because you're there a lot. Yeah. And is there any other, like, you can think about systemic, like, factors around, like we talked about, there's a lot going wrong with healthcare these days, like, especially with nursing. I think they went through a lot, like a lot of staffing challenges and all those. Are those some of the factors what do you think are the factors in the system that could expose them to PTSD that need to change?
We were asking about this. So we talked about direct exposures, CPR, maybe a patient's death, you're witnessing wounds or hemorrhages. Those are those direct things. But the indirect things, those systemic issues, challenges, those are sometimes harder to put our finger on, but they're also very, very important to talk about because that's what's happening every single day in many instances. So this is things that in the literature, nurses and researchers have talked about. So things such as dealing with issues outside of the nursing role. So those frustrations, feeling overextended, inadequate staffing to support patient needs, a lack of resources to effectively provide care. Those are all some of the organizational issues cited that do lead to increased symptomology and traumatic stress for people. But also there's this idea, and there's this theme that came out in some of my literature searches about the perception of care given. So negative perceptions of care have been linked to increased PTSD symptomology in nurses. So if nurses feel that they are providing substandard care, so maybe a medication error was made, maybe a patient's condition was misjudged, maybe you just feel like we could be doing better as a healthcare system. That perception of the care you're giving can sit with people, and that can cause symptomology. And also things such as providing futile care. So there is the moral, the ethical dilemma of just because we can do everything, should we be doing everything? And those things in healthcare, as we're changing and evolving, and our science and technology is changing and evolving too, we're able to treat in different ways that we did not have the options to 5, 10, 20, 30 years ago. And so now, because we can offer more, we're seeing those effects, those side effects, those, maybe they could have had a week at home, maybe they could have had time at home, and they wanted to have everything possible. So that's sitting with us is, ooh, was that the right choice? But again, it's individualized. And I think just the contextual exposures, and that's what nurses are being faced with every single day.
Yeah. And just based on your lived experiences and, just talking with maybe the nurses around you, and I know you lead a nursing team, what are do you know, like some of the real life experiences? Can you think of any that you've heard of that you'd like to share? I'm just curious to know.
Yeah. I think even just what are we seeing every day? So just this past month, one of our teenage patients had one of the most aggressive tumors that were eroding his skin. His entire back was covered in this tumor. They were managing bleeding. They were managing pain control, but every single hour, 12 hours a day, this is what you're dealing with. Like, you're seeing these massive wounds. And when I compared, and when we started talking about, like, our nurses experiencing PTSD, when we think about wartime or deployment, when they were seeing, these things, maybe not in the United States, but in other places too, like, our nurses at the bedside are also witnessing these wounds, these hemorrhages, these things like that you do see in wartime situations. And it's very different, but many times people don't talk about that. These are traumatic things that we are not always preparing our nurses to enter into this workforce. We're not preparing maybe our nursing students, or during those orientations, are we trying to shelter them from the really tough families or the really traumatic end-of-life situations? What are we doing? And the reality is that, especially in the acute inpatient environment, this is what we're seeing. More things are being able to be treated outpatient that are outpatient. So if you're in that inpatient world, you're dealing with the highest acuity, the sickest of the sick. You're seeing things like never before in our profession.
And what does usually you see it happening? Like, people go through these events, do you think they have the space to talk about it, or it just kind of swelters in for a long time until they finally realize, something's up with me? Because I've gone through PTSD too, so I know a little bit what it feels like, but I'm just curious. What do you think?
I think it's twofold. So it's very individualized. And I think it also matters on the team that you have around you. Are people saying, suck it up? Why is this generation not able to handle it like I could handle it? Or are people saying, yeah, what's going on here? Like, I'm dreaming about it. I'm thinking about it. And I think maybe with COVID, that just shed light on, we're all feeling this rush of, we weren't prepared for this, and now we're taking ICU level patients and doing things that we weren't doing before. So I think because of media and exposure, we're able to see and connect and kind of hear many different stories. And maybe that's one way that people are kind of able to say, like, ooh, what's going on here? And we hope that people are talking about it and being supportive of each other. But that's not the case everywhere. So that also is where your teammate and your work environment matters. So coworker support, leadership support, depending on how people are managing or kind of allowing you to express those emotions, matters. So if you're being told you shouldn't feel like this, or that's not a thing, this is a you problem, well, maybe I'm not going to tell anybody that I'm struggling. Maybe I'm not going to ask for help. Maybe I'm just going to internalize this for many years and just kind of sit down within myself. But if I'm in an environment where my peers talk about when they're struggling, my managers and my supervisors and my hospital leaders have employee assistance programs and talk about, hey, you as a healthcare provider, your mental health is important to us, and you should be taking these opportunities to explore these resources, that changes the conversation. And maybe when we can shed light to say, it's okay to not be okay, and this world that we're dealing with is not natural. Everybody doesn't walk into the same rooms and situations that we in healthcare deal with every single day. So how do we support each other? But how do we as leaders and institutional leaders and also legislative policymakers, how do we shine that light? And how do we start saying, we deserve a safe work environment. We deserve these resources because of the work that we're doing.
Yeah. And you're kind of right. The culture and environment matters because you think about, if somebody else is talking about it, like is there a space where the other person would talk about it or no? And then you think like two times before, should I be talking about it or not? I was talking about my own story. I lost a patient unexpectedly, so I'm also a pediatrician, and I was a new mom. I think my daughter was 6 months old, and it was a very tragic outcome of a patient similar in age. So for months, I felt like whenever there was a similar diagnosis or something similar, I used to get a lot of flashbacks in the hospital. And I didn't know at that time, if that was PTSD, but it sure as well felt like it. But at that time, I felt like if I go tell someone that I'm having these symptoms, and even though I don't think the culture was bad, but just that feeling that if I go tell them, they will feel that she wasn't strong enough to, go through this tough situation and this is like a normal thing, like that kind of feelings. I think there's also like a lot of internal talking that we do to ourselves when we go through something like that. Yeah. um and so I think that also kind of just goes all along with the entire culture of just medicine in general that still pervades, even if a particular institution is better than the others, but just the entire culture that we grew up in is you have to be strong enough, like that sort of thing. And you said some people are more prone to it than others. Are there like gender specific challenges or something that you can think about in particular?
So there's some new literature kind of being done with ACEs, so adverse childhood events, and just thinking how that impacts even your decision to go into a field like nursing or different things like that. So people are coming into work, into our healthcare profession with their own life story, with their own things that they're dealing with every single day. And maybe those workplace triggers put somebody over the edge where somebody is able just to kind of maintain. So it's, like I said, that's where a lot of that variability comes in. So within the literature too, when I'm looking at things like gender, workplace inpatient versus outpatient, years of experience, are you a mom, a dad, are you a parent? Like different researchers have looked at these demographic variables. But again, the literature is not clear. So sometimes gender, female, had been shown to have increased symptomology than their male counterparts. However, that's also important to note that who is your sample? When we work in a predominantly female self-reported gender, it's important to make sure that those sample size that you are having to compare your samples to are substantive enough so that you can make those claims about maybe there is more of a predictive factor here or there. But then other studies say that gender does not predict it. Other studies say there's no statistical significant finding. So it really varies. And when we talk about years of experience, so not necessarily your age, but just like years of nursing experience, because that's something that I looked at. Sometimes, again, the literature was unclear. Sometimes being a newer nurse or newer to the field, that was associated with increased PTSD symptomology, when in other studies, they found that the longer that you were a nurse, that was actually increasing your risk for PTSD symptomology. So again, it depends on the sample studied. One author actually looked at new graduate nurses at 3 different time points in their career, and they found that their PTSD symptomology increased over time. So again, there's a lot out there, and how we interpret what that is going to be important. But it's important. It all comes down to the fact that PTSD is occurring in healthcare workers. We need to take note. But there are perhaps many factors such as years in the field or subspecialties that might be more predictive as well. So we need to be aware of that, but we also have to try to sample more people, and we have to do it with the similar tools, and we have to do it consecutively so that we're able to kind of trend these factors and trendings over time as well. So we need more literature. We need more people talking about it, and forums like this where we can just say, like, let's talk about the hard things in healthcare. These are so important, truly.
Yeah. And you talked about past trauma, like that was important. I think that when you looked at it, does that play a role as well in your risk of PTSD?
So it's interesting because many authors did not separate that point out. Only 1 or 2 that I found actually said that when they were utilizing the tool, they directly told participants to answer just on work-related experiences. So were people answering based on maybe they were in something traumatic, maybe, whether that was a car crash or something else, maybe something else happened that might have been influencing their time. So it's important as researchers when you're setting up your study to be very specific about how are you asking these questions. So for my PTSD work, I was able to reach out to the U.S. Veterans Affairs Office to be able to use the PCL5, the post-traumatic checklist tool, to be able to say, I want to modify that SNEM. And I want to make sure that people who are answering this questions, that they're answering related to work-related exposures and not necessarily outside personal exposures.
Yeah. Okay. And so for anyone who's going through PTSD, a nurse, a younger nurse, or a younger healthcare worker, what advice would you give them? What are some of the signs and symptoms they can recognize in the terms we kind of talked about it, and how can they help themselves, just from your own experience as well?
I think I would say, if you're thinking about it, if you're talking about it, if you're finding this podcast, you're on the right path. And I want to say that you're not alone. Even just us having this conversation, we're coming from different backgrounds and experiences, and yet we've experienced some of the same symptomology. And so what I would say to those people who might be experiencing it is just have grace with yourself, but also there are a lot of resources out there. So even just starting with your own organization. So many have employee assistance programs. You could talk to HR. You could talk to, if there's an office of like a office of clinician support or something to that extent. Ask your manager if you feel comfortable. Ask an educator. Ask a peer. Hey, do we have anything for us as employees? Maybe just starting that dialogue. But then also Google. There's a lot of resources out there. So even just looking at like the American Nurses Association, you might not be a part of them. You might, but they actually have a PTSD toolkit. So did you know that there are videos? Did you know that there are tools and resources out there? The U.S. Department of Veterans Affairs has a PTSD site as well that you can learn more about it and see what resources are out there. People want to give away these resources to help each other. So I think just seeing that first kind of step about how do I find what could help me potentially, there's a lot of things out there that are available widespread for individuals.
Yeah. And do you know of any successful like intervention programs or that are in place in hospitals that have reduced PTSD in healthcare workers, or early recognition maybe?
Yeah. So that's kind of, I want there to be literature on that can show, but it's kind of mixed. So even within the literature, debriefings, just thinking about that tool. Many hospitals use them, many might have informal. So depending on that, debriefings could actually be extremely beneficial or also harmful. So are you doing a debriefing that is bringing up all of these emotions to the surface, and then you're letting employees sit with them, and then there's nowhere for them to talk about it further? So that can actually be more harmful or protective. So there's interesting articles out there just about the way and the method that debriefings are done. So just being thoughtful about, if I'm instituting a debriefing, am I doing it the right way? Am I ensuring that employees have somewhere to go with those feelings that maybe debriefings are bringing up? So not all debriefings are the same, but there's different opportunities. But I think what matters is just a culture change of acceptance about talking about mental health, like taking the taboo nature out of it and saying that it's okay if you're struggling, and how do we help you? So I think as leaders, as peers, as colleagues, creating an opportunity where you and yourself, whether you have experienced it or not, but just being a safe space for somebody, and to know that difference of, hey, it sounds like you actually need help. And can I help talk to our manager about this? Can we talk to somebody in HR? Can we talk to somebody who might be able to help get that need that you need? Because, as peers, we're not social workers, we're not therapists, but I think identifying, hey, my colleague is calling out a lot, or my peer used to always be joking in the back room and now they're not, or they're very much withdrawn. So I think even just like having that culture and that awareness of like, how do I look out for my team, also myself, but my teammates too? Maybe I know we were in a very traumatic situation. Am I checking on you? Am I sending you a text? Am I asking you, hey, you want to go grab coffee? How am I just trying to recognize that the things that we experience at work are and can be very traumatizing?
Yeah. And, peer support groups. Do you have any peer support groups at your institution where people are kind of trained to help when something like that happens? Yeah.
Absolutely. I think that I'm very fortunate that I am at a more of a research rich organization right now. But something that I was able to be involved in was co-creating a nurse-driven one-on-one real-time support. So nurses come into their shift, and that's what the HART program, the HEMONC, Stem Cell Transplant Advancing Resiliency Team is. You're a nurse, And in that role, you are focusing on, hey, who am I checking in with today? Is it one-on-one with staff? Is it group debriefings? Is it holding things like tea times, remembering patients? Is it just doing education on well-being of how do we increase your resilience? How do we just kind of come into that world and connect people with wellness resources, help them have a safe space to just step away from your assignment. Let's just have a break. Let's focus on you. Some of these coaches do different integrative therapies for staff. So they'll offer things like Reiki or massages and just try to have, hey, this is your 5 minutes or your 10 minutes during your shift that I want you just to feel like somebody cares about me. I can exhale just a little bit more. So supporting that is crucial, because healthcare environment and the demands are never going to stop. But what are we as leaders trying to say, this is a priority and I really can't budge on this? Or how do we support this with what we have, and how to make that priority? Because it matters to care for your staff, and it matters to show them that things like mental health and emotional health, all of that does impact patient care at the end of the day. And how do we show support for each other as human beings? Yeah. It matters.
And with that program, are you supporting staff every day, or when a bad event happens?
Yeah, no, that's a great question. So for what we're able to support right now is about 3 times a week, 3 different 12-hour shifts. So the coaches will try to work like different day, night to capture both shifts, different things like that. So it's not 24/7. I wish it was. But we're able to support 3 12-hour shifts about a week. But if something happens, like we know that we have we've had a patient for 6 months, a year, 2 years, we've been caring for them and they just passed away. This is going to hit staff. How do we make sure that on those shifts, those HART coaches are offering what we call a tea time? So we'll dim the lights in the back room. We'll just get the tablecloth out. We have those fake candles with like the battery operated one. Okay, let's turn the lights down. Let's create more of a calmer mood. We get this coffee tea cart. We offer this for staff and we just talk. It's a place to reflect on good memories with that patient and that family. And just like it just opens up the dialogue of how we remember that patient or those family members, and how do we honor them and continue to serve those next patients that are still in all of our beds. So it's a hard job. Healthcare is really tough.
Yeah.
And we have to figure out, as leaders, as peers, as individuals, how do I support myself with my team, and how do we carry each other through?
And when you're doing these things, are they disengaging from clinical work, or do they have protected time? I'm just curious.
Yeah, no, great question. So truly it's during your shift. So whether you hand off your phone to try to take like 10 or 15 minutes with the HART coach, that's ideal. But many times it's, I can't get away from this assignment today, and that's the reality of it. But these resources are coming to you on your time. So whether that's, I only have a minute right now doesn't work for me, but I'm going to circle back with you. I'm here for 12 hours for your shift. Whether it's, I have this beautiful candy basket, I'm going to give you a Pop-Tart. I'm going to give you something because you're going to need that after you're done giving all of those meds. So it's even just like those moments of small check-ins, but just saying like, yeah.
Yeah, that makes sense. That's the reality of it, right?
I know.
Yeah, you can't always make time. Yeah.
I know.
Yeah.
But that's why it's bringing resources to your nurses. So yeah, some institutions have these beautiful wellness rooms, but who can actually take a break off the unit? Who is actually leaving their unit to go get a 30-minute lunch? A very slim percentage, I assume. So how do you bring stuff to the unit? How do you bring it during their work shifts to try to say it's here on site? I know it's really hard to get your breaks, but like, let's utilize us. Let's utilize, handing off your phone to a peer. Make a buddy system at the start of your shift. I'm going to see the HART coach here. I'll hold your phone. You hold my phone. We'll swap out. So yeah, it's a culture shift too. Mm-hmm.
Yeah. One of my favorite things when I work on the PEDS floor is when I hear laughter from the nurses station, because I know they're always like so stressed all the time. But there are some moments when everybody's like cracking up, and like that's one of my favorite. I'm like, I'm glad you found that moment in your day. So just
absolutely, it matters. This work is heavy, and it will continue to be heavy. But how do we make each other laugh in moments? And you asked at the beginning of the shift, those small moments of joy. How do we make each other laugh and remember, why are we coming in every day and holding each other together as teammates? Because that's at the core what matters so much. Each other.
What tips do you have for young nurses on how to maybe minimize the risk of getting PTSD or preventing, just like some personal tips on a personal level? I'm just curious, is there a way we can really do it? Yeah.
So I think resiliency, that's one of those buzzwords. What does it mean? Is it actually working? But I think just kind of giving yourself tools. So whether that's incorporating your own mindfulness practice, whether that's 5-minute yoga meditation or 5 minutes of yoga, a meditation on your app, finding things that work for you is so important because healthcare is hard. That's just what we're going to say. So going into it with, I've got some self tools that keep me healthy at a baseline. So whether that's I've got a support network of peers or family, or I really like my hobby of running or doing scrapbooks, of reading books, whatever it is, keep those things because that's what's going to help you when those hard moments continue to happen. But also if you're new and coming into an organization, during your interview process, ask, what supports do you have for staff? How are you supporting our staff that are dealing with really high acuity and end-of-life situations and everything like that? Ask those questions to the hiring managers because it's important. And if they have nothing, then maybe that's, is this the right place for me? And just kind of being very thoughtful about, okay, I want to work in an environment that is going to support me as an individual too. So I think asking those questions and being thoughtful are also very important. Do your homework.
Yeah. And how about after like a tough traumatic event? Because you've been doing this for 10 years. It was interesting that you said, debriefing may or may not be helpful.
Mm-hmm.
What is some of the things you can do like after a tough traumatic event? Do you pause and reflect? Do you keep going? Like what would you say?
I think it depends on what's going on in the moment. So it's okay. I want to be able to process this, but right now, the other patients, the other situations, I might not be able to. But if you realize like, hey, I am actually not okay, you need to tell somebody. Tell that charge nurse, tell your peer nurse, like, I physically need to step away from this bedside right now because I don't feel safe to continue on, or I'm not able to provide that care. So I think just doing a quick check-in with yourself on, okay, am I going to have to compartmentalize just a little bit? And after my shift, I'm going to really look into my emotions, or am I not well to continue on right now? And I physically need just a little bit of a break, remove myself from the unit to see if I can carry on in my shift. So I think talking about it is really important, and doing a self-check moment of what's going on right after that is very important. And then after your shift ends or whatever it might be, kind of self-reflecting and saying, okay, is there a debrief? Do I need to talk to my manager about, hey, this went really poorly, and how do we prevent this from happening again? Or what is actually happening to try to prevent this situation from happening again? The reality is many traumatic exposures are going to be unavoidable in certain positions. So there will be moments where patients code. There will be moments where things go south very quickly because of acuity. But how do we really look and separate at those things that maybe don't need to be occurring? So let's look at behavioral health escalations in healthcare. So one of the biggest, when doing this literature search, violence against nurses, violence against healthcare providers, that was one of the biggest triggers of post-traumatic stress disorder symptomology. So it was from patients, it was from families and visitors, and it was also from coworkers. So it's not just I had a behavioral health escalated patient, it's the visitors coming into my hospital, it's my coworkers being really mean to me. So it's kind of a lot right there. So then what kind of system improvements are in place? Does your hospital have a code of conduct? Does your hospital have protections for employees that say you actually are not allowed to speak to me or to harm me in that way? Do you have those kind of silent panic buttons? Do you have things that can help you if there is something going on? And looking at those system changes to try to help prevent those moments from occurring again in the future. That's huge.
Yeah. And a lot of what you talked about is, just empowering nurses to have the information, to know what the resources are, and try to go look for them. I'm just thinking, so if there's somebody who's struggling with this internal feeling of, this bad thing happened and now I am so much affected by it, that makes you feel that shame. I don't know if you've ever felt that, but you feel that shame that it affected you more than maybe it affected others and it shouldn't have affected you. How do you deal with that? Or do you think that's valid, or everybody goes through it,
Yeah. As I mentioned, we can walk away with very different experiences. Doesn't mean I'm any less of a nurse than you might be. It just means, hey, this hit me differently than you, and that's okay. But what I would say is that there is a big difference between needing a break and needing help. So do I need a few shifts off? Do I need to go on maybe, I just need to not come back that next shift because I need a mental break? Okay, that's okay. Then maybe I'll be ready to come back to it next week. Or do I need help? Did something else happen where maybe I need to think about an intermittent leave of absence? Do I need to think about, hey, I need to get set up with a therapist and I need to actually work through these steps? So a lot of it comes back to self-advocating, which is probably one of the hardest things to do, especially maybe if you're new in an institution or newer in a role. How do you say, hey, I'm the new guy and maybe I need a break? That's hard to do. But it's important because you're never suffering alone. And if you can help change the culture, just because it hasn't been done before, doesn't mean it shouldn't be happening. So maybe you can be that first person to make it okay if people start talking about, I need a break, I need help, I need to do something else. And maybe even what I've heard about too with extremely traumatic situations on units, they can actually bring in crisis counselors. You can bring in different things like that to help units work through certain situations. So being able to self-reflect and advocate and say, like, I need help and I'm going to be okay with that because I have this entire career ahead of me and I want to continue to do this. Or maybe what we've seen in literature, some people say, this is not for me and I'm out. And that's okay too. It doesn't mean you failed as a healthcare provider. It means that for you, the right thing for you right now is to separate yourself. Maybe you'll come back to healthcare and maybe you won't. And maybe this is an unpopular opinion, but that's okay. And sometimes retention is not the gold standard. Mental well-being should be. And that's my views. So it's important to keep your people and it's important to keep them happy and healthy, but it's also important to talk to people and say, it's okay if you feel like this is not the right move for you right now, and support them where they're at all times. Because that, for that individual, will affect them lifelong. And it's important to show up in those moments.
Yeah. You said something very important, that some people do decide to quit because it's that event. Even after one event, I have seen nurses, I've seen healthcare providers. There's this one event that changes the entire trajectory of the career, and they can go on after that. But I'm glad that you said that that is okay. Like, you got to do what's best for you.
Absolutely. You do. And it's okay to say, I am going to prioritize me, because at the end of the day, you don't want to do yourself a disservice. You have to kind of be able to say, like, where is my heart? And if I'm, coming into this job that needs me to be on 100% of the time, where am I right now? Maybe I need a break. Maybe I need a few weeks off. Maybe I need this or that. But I think just being able to self-check in and realize where you're at, because that might create opportunities for you to process something traumatic and come back to that field in a different way. So I think that it's hugely impactful.
Yeah. We talked a lot about young nurses. You said that in some studies it showed that people who've been working over time, the PTSD can increase. So what can we say about the long-term effects of PTSD in a healthcare provider? Does it present as burnout maybe, or it's kind of...
Yeah, I think that's important too, because a lot of nurses are like, oh, I've heard of compassion fatigue. I've heard of burnt out. I've heard of these things, and maybe they're buzzwords, maybe they're not. But PTSD is actually its own entity, and that's different. So when I talked about needing a break, I'm burnt out, I've got that compassion fatigue, I need a break. I'm experiencing PTSD, I need help. So I think that's where that dividing line kind of separates, and you do need to talk to somebody to work things out on a different level than maybe just needing that break. But what's interesting is that, as we mentioned, exposures can accumulate over time. So that's where maybe that longevity of your career, you've seen a lot, you've been through a lot. Something is working because you're able to continue on, but maybe something's not working and you're kind of shutting that away and you're not looking at it and I'm just going to keep on. So I think just kind of checking in with yourself too, because I think that there's a lot of value that we as researchers can learn about too for those nurses that do stay at the bedside and those nurses that are able to carry on despite all of these situational stressors and these moments and these extreme events that happen. How do you continue on? What's working well for you? And how do we maybe find some of those things, whether it is components of resilience, components of whatever that might be within yourself, your self-efficacy, your drive, whatever it is, how do we take pieces of that and teach different generations or teach other generations? How do we tap into that and explore that a little bit more? So it's interesting.
Yeah, I think that's a great point and something that needs to be researched maybe. What is one message maybe, or your message for the leadership or people who are in control of organizations based on all the research that you've done on PTSD would be?
I think my biggest call to action is awareness. And if you don't have an awareness of PTSD in the profession, there's a lot of articles out there. There's quite a few, but there are many others. And let's start making that part of conversation so that when we're in these rooms and we're able to make decisions, how do we keep the nurse or that healthcare provider at the forefront of those decisions too? How do we make sure that we're enacting and enabling a culture and a work environment that promotes safety and promotes trying to create a culture where, you have psychological safety? It's imperative to be able to speak to those things, but also realizing that healthcare in 2025, we as leaders have to be aware of these workforce issues, and we have to try to incorporate them because this is what our staff are experiencing. So how are we educating ourselves to be able to handle this?
Yeah. And do you have any parting words for the nurses who are listening to this, or anybody who's going through PTSD in the nursing profession? Because I think it'll be really helpful.
I think I first want to say, you're incredible. Thank you. You're showing up, whether that's all of it. I think these nurses are incredible. And I think talking about it is a huge, important step. So what I would tell these nurses are, you're your own best advocate. You advocate so well for patients and families. Sometimes it's hardest to advocate for ourselves. And maybe just saying, okay, I'm going to put myself first, or I'm going to advocate for what I need, because that is advocating for patients and families at the end of the day too. But being able to help yourself and being able to say, what's going on with me? What's going on with my team? I think just kind of having that self-compassion is huge. So I would say you're doing really well, and let's just keep digging and finding out what else is going on. But looking for those resources, spreading awareness, that's where it starts.
Yeah. Well, thank you, Michelle, so much for doing this with us today. Is there anything you wanted to say and we haven't talked about today?
I think we talked about a lot of things, but I would say just even some of those free resources, whether it's through the American Nurses Association, whether it's through your healthcare organization, whether you're struggling or not right now, maybe just say, what are those resources? Have a toolkit ready for yourself so that if in a month, in a year, you're like, oh, I'm struggling, how do I start to build up my own resources, my own kind of well-being to support myself in this profession? So start looking now. Yeah.
Yeah, just know what your resources are. Yeah, that's awesome. We have a tradition at the end. Thank you so much, firstly, for doing this today. I just love the research that you're doing, and it's such an important topic in all your advocacy for nurses. And I hope you find some more answers for us, in a few years.
Day by day. Yeah.
Day by day. We have a tradition on this podcast that we end the podcast with a poem. So if you'll stay with me for that, and then we're going to end. So PTSD often leads to self-criticism or guilt, but this poem, it's called Wild Geese by Mary Oliver. It's just a reminder to love ourselves and encourages kind of releasing that burden. So it goes, you do not have to be good. You do not have to walk on your knees for 100 miles through the desert repenting. You only have to let the soft animal of your body love what it loves. Tell me about despair, yours, and I will tell you mine. Meanwhile, the world goes on. Meanwhile, the sun and the clear pebbles of the rain are moving across the landscapes, over the prairies and the deep trees, the mountains and the rivers. Meanwhile, the wild geese high in the clean blue air are heading home again. Whoever you are, no matter how lonely, the world offers itself to your imagination. Calls to you like the wild geese, harsh and exciting, over and over, announcing your place in the family of things. Thank you once again, Michelle.
Thank you so much.